And when you start,
Super. Hello. How you doing? How's it going?
I need to talk to you about some pictures you took earlier
Okay.
because I contacted the young lady up at City Hall.
Hey Kevin, how are you?
We'll
Good to see you.
talk.
Okay. Okay.
You got my phone number?
No, I don't.
Just call me up.
Appreciate your vote in November. I don't know what I'm running for.
Ladies and gentlemen,
all right, I'm blessed.
can I have a microphone? Will everyone have a seat, please?
Yes, ma'am.
In case somebody get out of order. Okay. We're running a little bit behind time because of the unscheduled press out outside. But it's with pleasure that I would like to introduce our new director. Coming all the way from our lovely city of East St. Louis. And he's here for a listen and talk session. So we can say what we want and he can hear what's going on. And I want to say that our mayor may be here in a little bit to make an appearance. So Dr. Hatch, the floor is yours.
Good morning, everyone, and thank you so much for coming and giving a little bit of your time to come out and meet me and spend a little time. The way these are designed is just for me to have really a frank and intimate, collegial conversation with you all. Obviously, as the state health director, I'm coming from a perspective where I understand that all public health happens locally, and so it's kind of difficult. Or it would kind of be difficult to try to lead in the blind without going to the localities and meeting folks in the front lines and doing the work and learning from you in terms of what's going on here in your community. What are you grappling with? What are some of the challenges? And what are, most importantly, some opportunities for us to work more supportively and more collaboratively with you as you tackle your local public health priorities. So when we talked about this format, I said, what I want to do is just get around, share folks a little bit about my background. If they're interested, have them have the opportunity to ask questions about me, my background, my history, my approach to the job, and then most importantly, have kind of a listening session where I can talk about what's going on in your areas, and you get an opportunity to kind of inform me in terms of how we can be of more assistance. Also, I'd like to hear a little bit about some successes that you've had, both locally as well as any collaboratives that you have with the state health department, so we can build on those. I understand that it's a challenging time. We got the budget issues looming, and I'll speak a little bit about that because the pivotal question for us as public health practitioners is how do we practice public health in this context of a fiscal emergency, right? The state $9 billion or something broke for unpaid bills, and so it's very hard to look at our forecast in the future and talk about some of the most needy populations, which I know you serve here as well, when the bank is busted, right? And so I'm going to give you my perspective from a public health standpoint and what that means for us and how we together can go forward on that. And then lastly, I just wanted to make you aware of an opportunity we have. We don't have a whole lot of money nowadays, but we have just released another announcement in terms of a grant opportunity, getting just under $5 million or so a year for 5 years to help new services to really transform community transformation grant. And each grantee can get up to $300,000 to address chronic disease. And that's important because $300,000 can go a long way, but when you wrap it around with some of the things that you're already doing, when you're bringing in other partners and building other collaborations, then it can be a very positive start forward. So I do have that information for you as well. So before I go into a little bit of my approach, and just a couple of highlights of my background and what I'm bringing to this job, can we go around real quickly and just tell me, this will take a long time sometimes, listening to a lot of people, but it's important to me, and I'm going to leave some cards. The cards go around, I have a ton of them. Make sure that one person from your organization has a card, and then you'll have a way to get it. before we do the introduction, let me just introduce my team that came down and helped me set this up. We got Melanie over here. We got George. You guys all know Maryland. Okay. They basically helped me set this up. So I appreciate all the work they've done, and as you probably heard, I'll be going for the next 3 days, and the next week I'll do 3 days of work. I'll be outside. So why don't we start to my left?
Okay, Director, it's great to meet you. I'm Barb Holt with the St. Clair County Health Department, and we oversee our health protection programs with our environmental, public health, and infectious disease and emergency preparedness programs.
Hi, I'm Doug King. I'm with Eastside Health District. My focus is on environmental health and emergency preparedness. I'm the district administrator here overall with the program.
And I'm Jan Alley. I'm president of the board at Fiscal County. That takes me the rest of the township other than the chief for township. And active, I'm the Illinois Association of Boards. I'm Jan Board. I'm the St. Clair County Health, and I'm the director of administration over administration.
Mark Peters, the Director of Community Health for the St. Clair County Health Department. My program is oversee a multi-county lead agency for the HIV Care Connect program for the Northwest Cluster program for women's health, and we do a lot of work with schools and students.
I'm Robin Hannon. I'm the Director of Personal Health at St. Clair County Health Department, and we provide the clinical services and the health visit services, mostly for maternal health programs.
Go behind you.
Fair to Washington University in Utah.
I'm Robin Ross, Assistant Administrative Operations. I oversee all of our service programs.
Morning, Doctor. I'm Kevin Hutchinson. I'm Executive Director of St. Clair County Health Department. Work with the team here and also with Liz, the partners here in the local community. Also have the opportunity to serve on State Board of Health, and our department also serves as convener of the St. Clair County Healthcare Commission, which has a lot of our partners, our community collaborators, and we're working together on the issue.
I'm Ruby Allen with Eastside Health District. I represent Eastside Health District as their grant writer, and I am also one of their community liaisons. I do represent them in the community as well.
I'm the Director of I'm Annie Clark, and I'm on the St. Clair County Board of Health, and I'm also the Secretary of the Illinois Association of Board of Health.
Michael Doc Holliday, I am on the Board of Health of Madison County, Chairman of the Board. I'm also President of the Illinois Association of Board of Health. Welcome, glad to have you aboard. Thank you. Looking forward to working with you.
Director, my name is Kelly Corona. I'm the Director of Madison County Health Department.
I'm Teresa Macias, and I'm Director of the Jersey County Health Department. Small county, we have a lot of issues though. We have the only Christian Science college in Northern County, so we have, if there's outbreaks and things, we usually call this thing. So, little challenges there. Welcome. I'm Maxine Garth from Bonnie County Health Department. I'm the administrator. We are also a small county, but I think our health department's very mighty. We have home health and hospice. We have dental clinic. We have mental health and substance abuse. Green Sam Flowers. I'm administrator of Green County Health Department. Small county. We have the public health programs. We also have home health. We're in a rural, don't jump the county, so everybody has to drive. So that's kind of sitting we're in. Funding is real issue.
Marty Ware, I'm the Assistant Administrator here at Eastside. I'm responsible for the financing and the dental department, which has come to fruition now to actually serve adults and children. And we also have a school-based clinic for dental. So those are the major areas that I'm involved with in HR and all the other administrative tasks.
Hi, I'm Harold Lowry.
I am the executive director of a non-for-profit agency here in East St. Louis known as WPT, Writers, Planners, and Trainers, where we specialize in community wellness programs. I'm also the liaison or the health czar for the New Salem Baptist District, which represents 52 churches in our community. And I also serve on the Illinois Department of Public Health Community HIV Planning Group, where I serve on the executive committee. Nice to and welcome to the city.
I'm Paula Brody with Southern Illinois Healthcare Foundation. We run the area's FQHC, provide primary care services, dental services, HIV services, and also the Federal Healthy Start Grant, which focuses on women and pregnancy and infants.
Well, my name is Anthony Vincent. I'm the director of the emergency services for the city of St. Louis. I'm responsible for managing disasters, preparedness for the city of St. Louis.
I'm Alvin Park, Mayor of the City of East St. Louis. Welcome to the City of East St. Louis. Yes, glad to see you here. Yes, sir.
I can tell by the voice if it's someone a problem. So, did we miss anybody?
Well, you know who I am.
Yes.
Oh, good morning, sir. I'm Stephen Crucius. I'm Regional Coordinator, Illinois Emergency Management Agency.
Okay. So, thanks everybody. You know, we have scheduled about an hour or so to have this dialogue. So I'm not going to spend much time on my background. I think my background has been published, and you all may have read it and things like that. But I just wanted to give a few highlights that you couldn't have read about my background. One is I asked Marilyn to take me around the city because I wanted to see the context. So we got here, you know, about 20 minutes early, and we drove around the city, and I got to get a little bit of the flavor, at least visual, of the city. And remarkably to me, it wasn't unlike where I grew up. So it was very familiar. Everything from the churches to, you know, to the corner lots to some of the stores and things on the corner are very familiar to me. What you won't read in my background is that I actually grew up in a similar situation, in a similar community. Single mom, 4 kids, welfare all the way through, you know, middle school, and I grew up in what I would call a deficit community. And when you have a deficit community, that is public schools that aren't really providing the best education, when you have, you know, the neighborhood house and the free lunches and the other things that you have, and when you understand that you have a deficit in the area of health care, and what I mean by that is that our local emergency room or local urgent care was really my place, my health home. My dental plan consisted of the CREST school program hygiene plan with toothpaste, toothbrush, and red tablets. So that was my dental plan, and that was my health plan. So out of that grew the unique understanding, first-hand understanding, but also a passion and a commitment to really try to get back to communities. So when I did my education, I chose to do it on the South Central Los Angeles at a place called Kingsview Medical Center, LA County Hospital, which is in the Watts area of South Central LA. And their mission to train physicians there is very unique in that they want to train physicians to work in underserved communities with competence and compassion. And that's where my foundation was. Now, along the line, I went and got other education, but I have been a public health practitioner. That is, someone working directly in public health at the state level, the city level, the global level, the national level, my entire professional career. I come to you most recently from being a local health commissioner or health director. And so I understand what it's like to be out there. Sometimes it feels like you're on an island and understanding your health priorities. And sometimes having a disconnect with the state health director, state health department. I understand what that's like. There's 2 do's and don'ts that I learned in that job, and I spent about 2.5 years in that job. One is, I'll tell you a very brief story. I was at a meeting, and the state health commissioner came to that meeting, and he spoke for about 20 minutes, and then he was out the door in class. And so I said, oh, well, I'm the new health commissioner. Let me follow him out so I can get a word with him. Well, so I kind of cornered him in the hallway. I said, Commissioner, and I'm Dr. LaMar Hasbrouck. Just took over a year ago, you know, at the Oakland County Health Department. Just wanted to meet you and share with you some of the things I'm doing. He basically kind of blew me off and said, okay, well, you know, talk to my secretary and see if we can get you on. So I took that, a little bit discouraged. I followed up repeatedly. I never got a word back from the office. And I said to myself, that's a dope. If I ever get in that position to be a state health officer, I'll never have that kind of relationship with local health departments. Then, his replacement, about a year later, was a gentleman who, during Public Health Week, decided he was looking for local health departments that were doing things that were good, initiatives that were good, initiatives that were innovative. And I was lucky enough to be one of the local health departments that was featured in his kind of 5-day tour throughout the state. And again, much like here, there was New York City, and there was everybody else, right? I know here that dynamic exists as well, but he came to a rural community where I was serving in Catskill, and he spent a day doing a couple of press events, highlighting a couple of our programs, and for me, that was really key, because it reinforced that we're doing some good things here that deserve notice, and somebody wants to tell our story, and others can learn from our successes. So that was a do. So again, I logged that and I said, if I'm ever a state health director, I'm going to make sure to get out and find out what's going on locally and be able to highlight and tell the stories that are going on throughout the state. That's why this is week 3 for me. Week 3? Week 4 for me? Week 3? Week 3. Okay, week 3, and here I am. Okay? All right. So there'll be observances. You know, Public Health Week is every year, and during that time, I'm going to use that also as an opportunity to get out and highlight local health departments and what's going on. So I just want to give you that as a backdrop of who I am, which you never read on paper. Okay, so I'm sincere about my job, I'm serious about my job, and I'm passionate about my job. And my job is really to improve the health and safety of the citizens of Illinois. That's my job. Now, so how do we do that when the bank is busted, right? $9 billion, and we know $2.7 billion in Medicaid. We have unpaid bills only going to get worse. So the governor has proposed, among a number of things, the pension we won't talk about, because that doesn't impact us directly in terms of health, but the Medicaid system we will talk about, and we have to talk about it just very briefly, because we understand that for the underserved community, right, that is a very important piece of the safety net, right? So from my standpoint, I understand that when the governor talks about $2.7 billion in cuts, or reducing that footprint, it can be a little bit alarming and a little bit discouraging. It can also seem like it's dismantling the Medicaid. But from my perspective, it really is a gesture to rescue the Medicaid. And the reason why is because if our Medicaid system, which is on the brink of collapse right now, actually collapses, we're left without a net, right? And a lot of people are going to be without care. I mean, a whole lot of people. So we have to take some steps. It's like, how do you stop the bleeding? What's the first step to stop the bleeding? And so, you know, getting rid of fraud, getting rid of, you know, and looking at eligibility and making sure folks aren't getting services who don't need to get services and all that kind of stuff, which doesn't impact me directly in my office. But the other piece of the $2.7 billion, the 0.7 or 700 million, that is a public health initiative. In fact, that's my first public health initiative that I get a chance to back. And it came from the governor's office. And that is the tax on cigarettes, right? Because if we, all of us know, there is nothing that has a bigger impact in terms of preventable and premature death than tobacco-related health conditions, right? It's not just lung cancer, it's not just emphysema, it's the whole cancer, it's heart disease, it's everything. So as a public health initiative, to do any strategy that's going to decrease the amount of smokers that we have is a no-brainer, right? So this tax will not only generate $700 million towards that 2.7, and that's a good public policy, that's a good fiscal policy, and it helps to try to stabilize our Medicaid safety net. But also, when we talk about taxes, it's $4 billion a year that we pay in this state for tobacco-related illnesses. Medicaid puts the bill of $1.5 million in that. So we're really talking about, number one, decreasing recruitment smokers, so our youth who never go on to have all those diseases and those problems. Number two, decreasing active smokers, okay? Because we learned, the research shows that when you make a significant bump in the cigarette tax, a lot of folks stop smoking, and a lot of folks never start to improve. So it's a very, very prudent, and I think timely, public health initiative that came out of the governor's office, but I'm throwing all my weight behind it because it makes good sense. And so I want to encourage you all, as you think about that and how that might impact you and your constituencies, as a public health practitioner, anything that's going to reduce tobacco is sound public health, okay? So that is my position on that. And we got to stop the bleeding so that we can ensure that there's a Medicaid for the future. All right, it's a rescue in my mind. And so, so that's my piece on that. Now, with that, yes.
Quick, I'm not trying to belabor the agenda, but we have another provider who walked in. Marcia, I want her to stand up and introduce herself. I'm sorry to put you on the spot, but I apologize for being late. I got stuck in construction. I'm Marcia Johnson, and good morning, everybody. I am Executive Director of Comprehensive Behavioral Health Center, and we render services to mentally ill, to those who are disabled, alcohol and substance.
Thank you. Okay, so I kind of said my opening remarks. So what I want to do, if there's any questions on anything I said, or any questions on my approach to this job, I'll take those at this point. Otherwise, I'd like to hear from you all in terms of what I need to know. What do I need to know about you and your part of the world in terms of public health? Yes.
If I can get started, because we're going to have to leave. We had a meeting that we were about to go into. Mr. Crucius from Emergency Management, State of Illinois, along with Anthony Benson. Wanted to just share with you a couple of things. First of all, the City of East St. Louis definitely looks forward to your administration. And we recognize that the health community is a very big part of what we're trying to get done in this aspect of doing what we have to do here in the city, which is rebuilding East St. Louis. Health and safety are at the top of our priority list. In fact, we were in a meeting a couple of weeks ago with Ms. Pat Whiteside and also Rosalind over there doing some things that really put our minds into what do we need to do to make for a more healthy community. Also, this gentleman was there as well. We were trying to make sure that what we're doing is everything we can to establish healthy lifestyle, active living, healthy eating, but also doing a lot when it comes to the environmental health. You hit a very key initiative, and that is the use of tobacco. One of the things we are considering doing here in the City of East St. Louis is establishing a separate fee structure for even people having tobacco to sell, which may discourage some people who are currently selling tobacco in the city from doing so. Rather than bog you down with the details of it, just know that we are 100% behind what you're saying you're behind with the governor's initiative of A, increasing the revenue, but B, reducing the use of tobacco in the community. And if our just establishing a separate fee structure helps to accomplish that, we're certainly on board with that. We have several other initiatives that we've been discussing as here in St. Clair County, as the bigger community of East St. Louis. We are certainly on board with making sure that we are perceived as a healthy and safe community. So we welcome your new administration, look forward to your fresh and enthusiastic and passionate approach, and anything we can do to help you from a City of East St. Louis perspective, do let us know. Thank you. Yes, sir. Looking forward to working with you. Yes, sir.
Michael Dockall with Illinois Association of Boards of Health. We started about, I guess this will be our third call. We do town hall calls, and we try to involve every local health department, local boards of health in that call. So I'd like to open that up to you to be a part of that call on the 30th of this month, and that would be a great way for you to be able to reach other groups that are not able to get to you, or you won't be able to get to them. But it would be a great position for you to be in to put your format out to them. So we can give you the information about our call, and hopefully you can join us on the 30th at noon to help other people find out who you are, what you are about, and what you bring to the community.
Great, thank you. Now, does that call happen every month?
We do it. It's like every other month.
Every other month.
About every other month that we do.
Okay, we'll get your information.
Okay.
Thank you. Yes, ma'am.
I'll speak. Dr. Hasbrouck, Tony Corona again with Madison County Health Department. Our population, we're a little bit larger, we're about 270,000 people, but we are a relatively new health department, local health department. I guess I'm gonna have to stop saying that because we're almost 20 years old. We've been doing programs and services in Madison County on a local level now for about 16 years. That's still relatively new because we're very unique as far as how we started, when we were developed, et cetera. I'm happy to say we've conducted now 4 complete Illinois area plans, health assessments and priority plans. I'm sure you've already been briefed on all of this, but I think that Illinois, even though we do have some issues obviously with finances and that, what you're going to find as you continue to go out into these areas and see other health departments is that I believe we are all very passionate also about public health and making a difference within our communities. And in that line, the community transformation grants that you spoke of, we're all very excited about that opportunity to collaborate. In Madison County, some of our healthy initiatives, we have a problem as most as well with obesity and cardiovascular disease. We have quite a prevalence of that. This year within our plan, we also identified the need to really take a more introspective look at and collaborate and seek out and find stakeholders and a whole approach, if you will, on mental health initiatives. Rather than running parallel with each other, we need to somehow figure out how we can incorporate and combine knowledge and education and structure to be able to, I think, be more effective in our society right now, very few dollars. So I'm not going to belittle you. We all have very similar health priorities, et cetera. I think we all have very active groups of collaborators that, you know, want to participate in engagement activities to improve our communities and the health. And I, for one, am just very excited to hear your enthusiasm. I won't belittle local health protection grants, but I'm positive that George has done a wonderful job of explaining to you the importance of, you know, those foundation dollars, establishment dollars for us as local health departments to continue to operate. And I just look forward to working with you.
And I know that we were able to reestablish, I think we cut last year, we were able to get that back in the budget.
Wonderful.
And I just want to make this point, because we're talking about, or I just mentioned how we can practice public health in this fiscal state of emergency. And the other piece to the $1.7 billion is that as the governor's budget went in, assuming that we're going to get that $2.7 billion in Medicaid cuts. What that means is that somehow if we don't, we got to go back and revisit the budget and start cutting some more and finding that money, which means the local health protection grants may be threatened. So that's another important thing we need to understand is the budget right now is contingent on stabilizing a few things. If we don't get that support to stabilize them, then we got to go back. And it's going to be pretty hard because as everybody knows, we're already kind of cutting to the bone at this point. Yes.
Well, Eastside Health District is sits in a little bit different type of situation because in St. Clair County, we have 2 health departments. We have St. Clair County Health Department and we have Eastside Health District. I take care of approximately 65,000 residents out of St. Clair County. And of course, you know, we're right here on the borderline with Missouri. Sister to Madison County. So anything that happens in Missouri is going to come straight over to here first, and then it's free. So but as far as working on a shoestring budget, I've only been the administrator here 7 years, so I'm kind of a new kid on the block, but I've been in crisis for 7 years. From day one, I came into a crisis. It's not getting better, a little worse, but we have learned to do a lot with nothing. And then when you take the nothing that we have and take that away, it's going to be very interesting how we continue. We have begged, borrowed, cried, scraped, transferred, did everything that we know to do to keep our health department afloat. During the crisis, each year the local health protection grant money has been late. And it's like, how do you continue to work the health department and your money late? And we understand the fiscal constraints of the state. We understand that. But letters and saying that we're in dire need and we're getting ready to close our doors, we're at our very last, and there's nothing else that we can do, and we need to be rescued with some money to keep us going. Because we get to that point every year. And how can we do preventive measures when we're just putting Band-Aids on top of everything, trying to keep our stuff from just bursting at the seams? And it's very frustrating for us as administrators trying to do this. When we have our administrators meeting in Springfield, that's all we hear from one another. How are you holding on? Can I get some tricks from you in order to keep afloat until some money can be floated to us? But the lateness of everything, and I know the state's problem, but don't put public health last. You have to remember, prevention is the key. Don't wait until we have the outbreak, then you want to send some money. Our main goal is to prevent the outbreak from occurring in the first place. And legislators and everybody else think that's got it. That's just my soapbox.
No,
Okay.
no, that's, hey, I can climb up on that box with you and take it. I understand, I appreciate what you're saying, I understand, and I think that part of what I hope to bring is a voice to reprioritize public health to the General Assembly and to the other decision makers and help them understand that nothing touches the lives of residents like public health, right? It's the air we breathe, it's the water we drink, it's the food we play in, it's everything. So sometimes you need, well, every time you need somebody that's credible, but sometimes you need somebody that can make an impassioned story and really help folks understand how the dominoes fall if you don't put public health. So in being in your position, when I did it for 2.5 years, I had to consolidate clinics. I actually integrated the county health department with the county mental health department. Okay, integrated them under one roof, under one commissioner, to cut administrative costs and other common things. So I know what it's like to scrap and look for a little extra in terms of different approaches and different models. You can only do so much. You can only stretch the diet so far. And the point that I would make is that if we're looking at the financial crisis and we're looking at the fact that 4 out of every $10 and 39 cents out of every dollar is being shunted away from us and every other social service program directly to the pension and Medicaid, we got to come up with a formula to reverse that. So it may get a little worse before it gets better, but I can say that I feel confident that I will be a positive voice in getting us some of the attention that we need so that we're moving up on the priority list and folks understand what happens when we don't fund public health.
But also remember that all health departments do not operate the same.
I understand.
They're rural, we are sub-rural, as you want to call it. And there's a life outside of Chicago. So Chicago gets everything. We're downstate, don't forget us. And the way that Maxine may have to run her health department is different from the way that I run mine, which is different the way that Kevin runs his. And it's based upon the population that we have to serve. And that the cookie cutter image of all health departments being run the exact same way will not work.
I'm in a very peculiar situation in the work that I do in this community. Just to echo or to piggyback off something Mrs. Whiteside said, when she talked about her prevention efforts and that they have been in crisis mode for the 7 years that she's been the administrator. Well, I served up under a couple of administrators, 4 mayors, 3 governors, and so on and so on. And the one thing that I see in the community that whatever prevention efforts may be going on, they are compounded by the social determinants in our community. Unlike other communities in our area, East St. Louis is truly in a situation. A lot of my work has been in the HIV prevention arena, care and prevention.
to develop that continuum of care. But at the same time, I see the plight of the people that depend on that system as well. And it's just not getting any better. Most of them are Medicaid recipients, so that system is not getting any better. When you look at HIV prevention, Ms. Patton said that we serve the prevention dollars that comes to your department serves 8 regions in the state of Illinois. Region 1 through 8, and Region 9 is considered Cook County, you know, those collar counties of Chicago and all that. But although Chicago gets its own pot of money, but yet there are still times when special grants are written by the state that they use the numbers here in East St. Louis and St. Clair County region because we are the number 1 hardest hit area outside of the county for HIV, STDs, and a whole gamut of other things. But when we get these dollars, those dollars still go there. We get a very small percentage of the prevention dollars here in our area, and that disturbs me. Also, when we're trying to do collaborative activities, now to collaborate with, we do a lot of collaboration with Southern, with other agencies in the community, and to do those collaborative efforts, oftentimes the other agencies get the dollars and not Eastside. And I'm not, saying anything about other agencies, but I know that I'm on the ground. I'm in the community, and oftentimes I call upon the resources of Eastside Health District because that's who my relationships are with to help do the work that we need to do in the community. But we're in trouble here. People are still becoming infected with HIV at an alarming rate in our community. And for the most part, it seems like nothing is really done about it. I serve on the prevention board. I know we prioritize the target population. We prioritize the interventions to be done with those populations. So I know the needs of our community, but oftentimes because everything is in either transition or it's in crisis mode, we often get overlooked when it comes to the dollars, when it comes to the numbers and searching the areas to support the applications and all of that, and then look at our community. So I just think that if the money is going to follow the EPI, and the EPI is in St. Clair County, then those dollars should be following St. Clair County. Not just Eastside, but St. Clair County Health Department, Comprehensive Mental Health, all the other areas that does this work. So I just want to encourage you to take a serious look at the EPI and and just see and make sure that those dollars are followed. I think that would be a healthy start to your administration. Let's see where we are.
I appreciate that comment. And you said a lot. You got to react to some of it. One is you spoke about the social determinants of health, and that's something I understand well. My personal background, my background as a public health scientist, but it's also something that's on the state health improvement plan. It is those are the priorities that the Department of Health, the State Department of Health, identified in the United States. I believe it's number 3 out of 16 priorities. So that's something that's in our improvement plan. That's something that we need to roll out to all the communities in the state. We need to make sure that the communities that are impacted and affected most are getting the most attention. So the other piece is that when we talk about grant making and grant awards, there is a perception, maybe the reality is most of the money stays up in the Chicago area. However, I believe, as an epidemiologist, that we do need to make the resources follow the ethics. One of the things I asked about early on was the health rankings and how our community is using those health rankings to address their priorities. How are we, as a state health department, using the health rankings to funnel and shuttle our money? Because I believe that if you're going to get the state healthier, and I think we rank somewhere around 32nd healthiest state in the nation, if we're going to bump up to the top 10 and beyond, we're going to have to focus on those who are least healthy among us. So to me, that means that we have to start shunting money and resources and technical assistance, not just money, but the other things, best practices and other resources to those communities that need the most, exactly what you're talking about. We have revamped as of recent our grant review and grant making process to make it more transparent, more accountable, to make it more fair. And I think that one of the credentials and criteria that need to go into who gets money to do what needs to be where you are on that ranking and where you are in terms of the problem. That's a very problem. We're talking about the problem of violence and the public health issues. We're going to need to target certain communities. We're talking about obesity, and we need to target them all, right? So I think that kind of approach to grant making needs to happen, and that's something that I'm committed to doing in my administration, making sure that we're applying the nuances to our grant making, because it is about what's happening at the locality.
Dr. Hasbrouck, I appreciate you coming down here, and I just wanted to follow up a little bit, and maybe you can share some of your insight. I'm certainly taken with your perspective of New York City and the rest of the state of New York, and you smart guy, so you've already kind of got it here in Illinois. But when we look at the local health protection grant, and we look at governmental public health, I use the illustration, it's a chain of protection from Cairo to Cicero. And we have local health departments across the state, certified health departments that are carrying out, for the large part, infectious disease and health protection activities as an agent in the state of Illinois. We're operating under county ordinances, but carrying a decentralized state, we're really doing the heavy lifting of health protection for the people. When we look at allocation of resources, as George and others will explain to you, there is a formula, how it's distributed, and it's not just pure epi. There's an infrastructure issue. We have minimum grant awards so that the small rural county that has to have certain infrastructure in place to have a sanitarian and infectious control, those are things that we really need to have a vibrant chain of protection across the state. It's kind of a platform of services. So that's something that I don't know how your perspective of urban versus mid-sized versus rural, but I appreciate what you said. You're here to promote the health of all Illinois. And infectious disease doesn't have a border. This year, it comes across the river. People travel along the interstate, food safety, and all those things are very important. Those are fundamental things that really are at risk. Our system, we've been eroding. We've been laying off core services over the years. The state health department's lost its capacity. That's a real concern to us in terms of laboratory services, epidemiologists, and those people that have the expertise to help us operate the rapid response teams and others that we used to have years ago. So it's an opportunity, I think, for looking at what resources we have, how can we align them. When we look at the allocation of resources, there's basic infrastructure funding that has to be maintained to maintain the chain of protection. We have many health departments. You'll hear this as you go around the state that are really at the brink of closing the doors. In fact, some have closed the doors in these parts of the week. So what happens to our chain of protection? The basic infectious disease, health safety activities, those are critical functions that we're doing here. The other side is, it looked a couple of weeks ago, and it's not really something we're bragging about, but it's a reflection. Nation's Health had an article, and it focused on St. Clair County and Monroe County. Monroe County is one of the healthier counties in the state, which is great. It's just south of us, 30, 40 miles away. When we look at St. Clair County, we're low on the list, like 101 out of 150 counties. A lot of those herald the same social determinants of health. We have lots of issues. But we see there's lots of opportunities with the We Choose Health and community transformation. There's health departments working together, FQHCs working together, faith-based communities working together. So I guess there's an opportunity to leverage that. And your vision of how you see the state health, the leadership role, bringing the north and the south and the small and the large, a very diverse state, a very large state. So people are people when you get down to it. We all have basic needs. So I'd be interested in your perspective, maybe what you learned from New York, and how you can bridge some of those gaps from urban to suburban to rural.
Okay, thank you. Couple things. One thing that struck me, you got to understand this is week 3 from that, right? I got to, because I've been around doing so many things. One thing that struck me when I got here was the amount of local health departments. I think it's 102 you mentioned, or 92 or something like that. Right. Okay. So just from an outside, I don't have any. I'm a complete outsider. I didn't say that, but I don't have any connection in Illinois. applied and gave me a job. So as a complete outsider with fresh eyes, it just struck me that there's a whole lot of health departments. Okay, so the first thing I kind of asked myself is, should there be 92 health departments? You know, because if there's 92 health departments, that means 92 shops, 92 infrastructure, 92 overhead, 92 everything, and then you get a pill of this, a pill of that, unless you're one of the big ones, you don't really have the capacity or the infrastructure that you might want to run the health department and to do the central services. So, you know, I don't know the answer to that question, but if the answer to that question is maybe we have too many, or if the answer to that question is some of these smaller ones are just holding on, you know, maybe we may want to explore bringing some, in terms of providing public health services, doing some consolidation, at least of resources, and having hubs, regional hubs, that can provide the services for a geographic area. That way you only have one overhead, but then you have agents that work to do the local thing. Money comes to one, distribute that way. One model might help with efficiencies, may help the money, the dollar stretch a little bit more. But most importantly, there is a joining of technical expertise. So when you're talking about, well, we only have one sanitarian here, and you know the epidemiologist we don't have, well, maybe you can share the epidemiologist if you reorganize in a slightly different way. That may make more sense to the state. The other thing that struck me is that, like Maryland, who's one of our regional health officers, we have 6 of those. Seven officers. Okay. So, you know, borrowing from the New York, state of New York model, I think there's 5 regions. But the regional office actually serves as the decentralized arm of the state health department. So in other words, in the county, if I have an outbreak, if I have, you know Legionella in a nursing home or something, I go to my regional health office, and the epidemiologist is there, you know, the chief engineer is there, whatever, right there. So it's almost like having regional hubs that can serve all those districts. We don't quite work like that right now. There's a regional hub office. There are staff that use that office and come and go, but I don't think it's structured and codified in a way that you almost have an arm of the central office right there with that capacity. And so to that end, what they have in New York State is they have 2 designations for counties. One is a full health department that is large enough to have the whole contingency of folks that you need to handle stuff. One is a partial health department, which is supplemented by the regional office. So you don't have an epidemiologist, we have one in the regional office for you. You don't have a senator, we have one right there. So the capacity is there local for you to use. That helps your dollars go further. So that's a different business model of doing it, and it's one that that deserves exploring.
You said business, so I figured I had to put mine. Those who know me, I'm a purely business. And you mentioned something that I wanted to say that was really great, the standardizing of applications for the state, although we all groan. And did we not all groan with the first one going, oh my gosh, once we got through that process, it's now, okay, we know how to go, we know the information. That's great. That needs to follow through on a state level in terms of the reporting. St. Clair County runs in a given year almost 100 programs. And so help me, I have 100 different reporting requirements. And the infrastructure support of that is taking dollars away from my clinics and my environmental health efforts because I'm having to spend money. Oh, you need ABC. Oh, you need EFC. Oh, and so a standardization, in addition, a central clearinghouse for health. You know, if I have a question of IDPH, I got to start narrowing it down to, okay, which, this is a woman's health, oh, this is, so a narrowing down of that. So from a business standpoint, if that consolidation can flow through at IDPH to the back end of it too, I think there could be both cost savings at your end and at my end, because now I know, okay, this is the way we got to do it. It's not different for this program over here versus this program over here. So I applaud the first half of it and would hope to see some changes in the back half of it.
So thank you. And we are actually working on that. We're working with a CDC sponsored and recommended program called EPMS, Electronic performance management system, which will help us to have a common platform for all the reporting, so we don't have to do all the redundant reporting, and we can have it not only in terms of reviewing and ranking and grant dollars, but tracking grant deliverables and other things across the board. That's going to make everyone's life a little bit easier. We also know that the Health Information Exchange office is also pretty robust, and that's growing also. So I think that we're moving in that direction, and the point is not lost. You know, that a lot of manpower and a lot of money goes towards redundant reporting, and it just slows the work. So we're working on
That issue that you talk about, one issue that we were talking about at the time of our state meeting, the fact that there's no way to send your message, to the state, so we discussed about that, and that's going to make it more feasible to do it. It's going to be less cost effective doing that way, and that way it'll galvanize what you're trying to do and make it more simple, kind of say, but the message will all be the same wherever it's coming from, whatever department. When the state get it, it'll all be the same, that they're trying to say to them. So that's one of the things that we were discussing on that day.
I wanted to speak for the moms, babies, and children of Illinois and right here in St. Clair County. As you can probably tell, we have a wealth of information, and many of us serve in other capacities at the regional and the state level. I serve on the maternal child health section of the Illinois Public Health Association. The reason I got involved is we have found, while we do have wonderful services that we can provide to the women and affected children, it's not more fragmented. The services in Illinois are spread across many different agencies, and it's hard to kind of keep track of who to even call or contact to even find out what program changes there might be. We've done, I think, a really good job at the local level to try to integrate those services because it's one mom, one baby, one child. But at the higher up it seems we get, the harder it is to know to even talk to, and we're getting sometimes mixed messages, quite frankly. And then we talk about duplication in reporting, duplication in data. And I always say in Illinois, we're data rich but information poor. We don't always even get good reporting back, so we know how well we're doing. So I sort of don't want to lose sight. We have lots of needs in our communities, but our future are our moms and children.
Right, that's a very important issue. I have come up to speed a little bit on that issue in MPH and how fragmented it is, and read the paper from the organization, and read the Human Services Commission paper recommendation. My feeling is this. There's one end user out there at your business. So how do we create the best product so that mom and child can navigate the system and get the data? So if it's too fragmented, we need to revisit that and figure out how to bring it back together and put it in the most logical department, which is probably going to be public health. The issue is that so many folks, believe it or not, actually benefit from the fragmented system in one way or another. And sometimes they don't want to do give backs. They want to keep falling to go home. So we have to work through a process to identify what pieces to bring back, how to bring it back, and how do we get ready to absorb not only those pieces, but the resources, the staff, and everything that goes with it. That's like tracking, everything that goes with it. I am convinced that the right thing to do is to bring the maternal and child health back into the public. I'm convinced of that. What I don't know yet is the timeline in the process. So that is going to be worked through, and that's, sometimes that's a relationship building issue, sometimes that's proving that you have competent leadership and that you're poised to absorb those resources and those things to go forward. But that's something that I'm very aware of, and something that I'm going to do.
We're going to have to kind of wind it down. Our time coming to a close. They're not right, George.
Hold on, whatever you want to do.
No, back to me.
Let's get a couple more comments.
And I wanted to speak on behalf of the entire community that we all serve. Kevin mentioned the work of the Healthcare Commission, of which we are all members, and is now in its 21st year. It's appointed by county leadership and has grown in membership from the original 13 members back in 1991 to almost 40 or 50 organizations that come and go based on the work of our respective health departments and the I-plan process. Also want to note a compliment to the staff that you will be will be working under you and perhaps even give you a segue to the community transformation grant. At the webinar that the state hosted last week, they were very clear and emphatic about insisting that all candidates for the application process work together, even in so much as if they're in a shared geographic area. The state health department reserves the right to contact partners to insist that they do work together, which I think is something I have never seen before in terms of opening up, communication with the community process. And as the mayor alluded to earlier, certainly in our work over the last 20 years, we have felt the need to move from this crisis mode into a collaborative mode, and from collaboration to transformation. And what we're discovering is, with all due respect, that's not going to take an act of government. It's going to take an act of community. That's going to take an act of faith. And so we certainly see the state health department moving things in that direction. So thank you.
Sure, thank you. And one note, as you all probably saw in the application of the community transformation grant, it's earmarked, a portion of that has to go to rural communities. And then certain of those large counties that normally get the money can't even apply. So this money is really, and I like the approach or the philosophy of granting this money. That's kind of what I read, making sure money is shown to those communities that need most. Also, just a little note on the grants. We also understand, and I understand that sometimes communities that are smaller or may not be as accustomed to applying for grant dollars may need some technical assistance so that they can write an application, they can have an application that's competitive, and they can get those monies. So that's something that we're compelled or committed to making sure we have those resources as well. One of the reasons why the webinar, that kind of thing, just to bring everybody up to speed on the same basic principles of applying for grants, so that those communities are more likely to be competitive.
There's a bill that's before the legislature now that's dealing with comprehensive sexual education in schools. Are you familiar with that at all?
Where is it at in the process?
I think that this there will be a second reading. I think the vote is coming before the legislature during this session. I don't exactly know right where it's at, but maybe something you might want to look at. Okay. And take on.
If I could add to that, I think what it's trying to do is having it based on the national curriculum that specifically states sexual health teaching throughout the school across the board. And it's just hard for local health departments to get into schools and the community to have proper health education, sexual health education, almost public health education, and mental health education.
And I think the bill they would still be able to teach abstinence only, or encourage abstinence, but they're looking for a more comprehensive, curriculum to talk about broadband and sexual education, not just abstinence.
I think it's 3053, I'm not positive.
I'll take a look at it. We have, as you just mentioned, that my team has also been taking notes, so I can't remember everything. So they're getting it all down, and then I'll follow up. Yes, sir.
Last part of the legislation, one thing that we all should be doing is contact our legislators on certain items that we want them to support. That's crucial. That's where we want to get out to all health entities that if there's a bill that affects us, we must contact our legislators and let them know that we would appreciate they would support. And we just have to build a better rapport with them if we don't have one to make sure that we have that support in the Senate.
It looks like it's going to pass, and if it does, then it's going to come from your department to develop that curriculum.
Okay, well, thank you all again for taking some time and making yourself available for me to meet you and hear from you, and this won't be the last time.
Good. Thank you. Good.